My name is Satish Raj. I'm a professor of cardiac sciences at the University of Calgary in Calgary, Alberta, and I'm the medical director of their autonomic and syncope clinic. So one of the challenges in syncope is that there really have been no new drugs developed for syncope over the last 30 years. In some ways, even though it's a really common problem, it's a little bit of an orphan. It's not a huge, sexy market for the pharmaceutical industry to develop therapies for. One of the reasons is that a lot of patients don't need drug therapies. They need counseling, they need advice, they need preventative measures. But there's a minority of patients that do need therapy and they really suffer. And so what we've done at the University of Calgary, led by my senior colleague, Robert Sheldon, is to really look at drugs that have been on the market for other reasons and looking mechanistically to see if we can repurpose the drugs and show that they're effective for the patients with syncope, the recurrent fainters that really need therapy. So specifically, we've recently completed a trial looking at a drug called mitadrin, which is a blood pressure drug that's different than almost every other blood pressure drug because this one actually squishes the vessels and raises blood pressure. There have been lots of little studies with this in the past, but Dr. Sheldon's led an international big study to really answer the question whether it works or not. So we'll get those answers soon. The other thing that we've been looking at is using drugs for entirely different purposes that were approved. For example, we're using a drug called atomoxetine, which is a drug approved in North America for ADHD, attention deficit disorder. But mechanistically, it's very interesting to us because it actually amplifies the sympathetic tone, the fight or flight part of the nervous system. And we've recently conducted a study using tilt table testing and shown that it prevents fainting on the tilt table test. And so we're currently embarking on a study using real faints as an outcome, not just on the tilt, to see if this can be a new arrow in our quill, if you will. So there are really two issues when we want to translate our science to routine practice. The first is to develop the science. And so in the case of drugs like the atomoxetine, a tilt table test is fine mechanistically and physiologically, but we really need to get data on what this does to people in the real world. So we need to do studies where we follow people for at least a year, we follow them in their home environment with what they're doing and see if it helps prevent the fainting. And so we want to embark on those studies to try and determine if this is an option. But one of the challenges, not just in the syncope world, but in medicine in general, is that we can do a lot of good science and we can know a lot of things. But it really doesn't help unless this knowledge gets to the GPs and gets to the cardiologists treating the patients and then can then improve patient care. And that unfortunately is a journey that can take many years and sometimes even decades. And so the other half of what we have to do is really disseminate that knowledge, perhaps in forums such as talks like this, perhaps in papers, and sometimes through organizations, patient advocacy groups that can help bridge that gap between knowledge, the patient, and their provider.